Hello and welcome to another talk about erectile dysfunction. All right, our favorite subject. I'm Dr. Marc Greenstein. This is a talk by Coloplast, one of the makers of penile implants. I'd like to thank them for helping us organize this talk. Quick little agenda. We're going to do a little introduction. We're going to talk about erectile dysfunction. We're going to talk about our hopes and dreams, literally what patients have to think about it, and some other resources that are out there. So I'm Marc Greenstein. I am a urologist in Sandy Springs, Georgia. I've been with Advanced Urology for about 5 years now, actually over 5 years now. I was in practice in New Jersey 15 years before that, so I'm a little bit of a veteran. I do all aspects of urology. I do cancer. I take care of men's health. We do kidney stones. And then, of course, we focus on erectile dysfunction. And this talk is going to be a lot about the end goal, which is going to be getting a good sexual performance. However that's going to be, the talk is geared about penile implants, but it is going to cover all aspects of erectile dysfunction. We're going to try to hold our questions to the end, but if you do have some questions, please write them down, or you can put them in this little chat that's over on the side or wherever it is on your computer screen. And then here we go. So a little disclaimer, this talk is put together by Coloplast. I am just one of the vehicles that uses a Coloplast product, which is a penile implant device. We are very happy with them. They're an awesome company to work with. They take very good care of our patients, and so it works out very well for our men. So let's talk a little bit about erectile dysfunction. Erectile dysfunction you can describe as the inability to achieve an erection, inconsistent ability to achieve an erection, and something that only provides a brief erection. I would also like to add something where it is difficult to penetrate. So maybe able to get some kind of an erection, but you can't get inside to have intercourse. Affects a lot of men, 30 million a year. A lot of guys get it. We see guys in their 30s, 40s, all the way up to 80s and 90s. My favorite guy is the guy who walks in with his walker and oxygen, and he's upset that he can't get an erection anymore. So he's still trying to do his business, if you know what I mean. In almost every case, erectile dysfunction can be treated. There is an answer almost for everybody. I don't care what's going on. We usually have something that we can help somebody to maintain their sexual function. So what are some facts? ED, it's not a part of aging. So yeah, you get older, but that doesn't mean you have to lose your erection. I have plenty of guys that are in their 70s. They just need a little touch of Viagra, a little touch of Cialis, and they're doing their business. So it doesn't mean it's part of aging. There are plenty of young guys that lose their ability to get a good erection. We do see it a lot in people with hypertension, diabetes, depression, cardiovascular disease, which also includes stroke. I'm going to also include kidney disease, like people on dialysis. A lot of medications affect erectile dysfunction, specifically the diabetic medications, the blood pressure medications, the kidney medications, the antidepressive medications. They all are part of it. Stress, that's a big one. We all live stressful lives. We all have a lot to do. We're all very busy, and that can affect our work in the bedroom. Alcohol abuse, this is going to be very honest, but drunk sex does not work as we get older. It might be good in high school, college, and a little bit around there, but as we get older, drunk sex is not good. Tobacco, bad. Marijuana, bad. Obviously, I don't want to say obviously, but men who have had prostate cancer and they've had treatment, so if they've had their prostates removed, they've had radiation, or even other surgeries of the pelvis, that could be important too, certain colorectal surgeries, things like that. And then another big one, which I think is very undermanaged, psychological and emotional factors. There's people with depression, people with anxiety, people with PTSD, and it affects their sexual function. The other thing I'm going to add to this slide is low testosterone. Low testosterone is a big thing. It affects about 20% of men with their erectile function. And that's something that we are screening on a constant basis when men are in the office. And the last thing is sleep apnea. There are a lot of guys out there with sleep apnea, whether it's been diagnosed or undiagnosed, that causes erectile loss. So what do guys do? Unfortunately, a lot of guys don't do anything about it, and they just kind of suffer. They get frustrated, they get upset, they get angry. It affects their relationship. It affects their function at work sometimes, because they're just kind of in a pissed off mood. They're upset. Some of them, it leads to divorce. Some of them, it leads to sex therapy, where a counselor is getting involved to help these men. And a lot of times we can jump in as urologists to help these guys out. So how does an erection occur? Here's a quick little slide. We love our boner pictures. I call these the boner emojis, because they look like your emoji on your smartphone. And so there is some kind of stimulation. There's some kind of excitement. The blood vessels wake up. The nerves wake up. Blood supply goes into the penis. The chambers, the cylinders start to fill with blood. I'm going to try to be a little smart here and use my my little drawings. And the cylinders here start to fill with blood. They start rushing in. It starts to get engorged. The penis has a very strong connective tissue that lives around all these structures. And it acts like a boner. It's so strong, it gets that intense. The little veins that are living on the outside, they start to collapse, they start to close, and that's what holds the blood inside. When those veins don't work, or when the arteries don't work, that's when guys get erectile dysfunction, whether it's from diabetes, whether it's from stress, whether it's from high blood pressure or trauma or surgery, but that's basically the mechanism. So what do we do? So we got medicines, we've got injections, we've got it's okay, there. We've got sex therapy. So let's talk a little bit about this. And before I even talk about this stuff, what do we do in our office? So if you come to our office, you see me or any of my partners in advanced urology, we're going to talk to you. We're going to sit down. We're going to look you eye to eye. We're going to find out what's going on here. We may do an exam. Sometimes we do, sometimes we don't. If we think that there's a concern for low testosterone, we're going to draw some blood work in the morning to screen for low testosterone. We're going to talk to you about your sleep patterns. We're going to talk to you about your past history. Some guys, if I think that they have sleep apnea, in other words, they're a little bit heavy, they are up at night going to the bathroom, they say that they snore, or if their spouse or partner's in the room with them and they are nodding, yep, they snore, I'm going to screen that person for sleep apnea. I'm going to send them for a home sleep study. But a lot of times our first remedy is going to be some type of medication. Everyone knows Viagra. Viagra's been out for 20 years now. It's the little blue pill. And what it does is it stimulates blood supply to the penis. That's all it does. It stimulates the blood supply, but then your body's got to help take over. It's got to get that blood supply into the penis. It's got to keep that blood in the penis. You can't just take a Viagra and look at your penis and hopefully it goes up. You still need stimulation. You still need a little hanky-panky. You still need to get active. It's got some side effects. One of the side effects used to be cost. Viagra, Cialis, Levitra, they used to be $10, $20, $30 a pill. It's all generic now, so that's really not much of a side effect, but it can cause headaches, blurred vision, blue vision, upset stomach, sinus congestion, muscle aches and pains. And if it works, great. Use it. It's a great thing. Keep it around. You take it before sex. Some people, we have them take a low dose tadalafil, which is Cialis, every day. Injections. So let's say you try Viagra for a while, you're using it for a year or two, and you're noticing that it's just not as effective. All right, now it's time to go to the next level. So the next level may be something like a low intensity shock wave. That's something that we're doing in our office where it's this minor procedure. It doesn't hurt, but it's these little thumps that go into the blood vessels, into the tissue underneath the scrotum and on the sides of the penis to wake up that tissue, open the tissue up, generate new tissue. The other would be a penile injection. We do tons of this in the office. A lot of times I'll do this with an ultrasonographer. So the patient would come in, we would do an ultrasound of the penis. What do those arteries look like? What do those veins look like? And then while they get that ultrasound, we give them a test dose of a medication called either Bimix or Trimix. Now it's called Bimix because it's got 2 medicines in it. It's called Trimix because it's got 3 medicines in it. And it's basically medicines to stimulate blood supply. Each person needs a different dose. Some people need the same dose, but you get the ultrasound, you get the test injection. 15 minutes later, it's some kind of an erection. It could be a great erection. It could be a perfect erection. It could be a medium erection. The ultrasonographer is going to repeat that ultrasound. How do the arteries look? How do the veins look? And from there, we can determine how things are going. How do the arteries look? How do the veins look? If there's a vein problem, that's tough. That's a tough one. That's a little hard to work with. We'll talk about that in a little bit. If it's an artery problem, we can always say, well, let's go back to the Viagra Cialis. Let's try this injection therapy or other things as we continue to talk. We'll learn about that. But if you're a candidate for injection therapy, we set you up with a little vial. We set you up with some syringes. Usually we use a compounding pharmacy for this. And when it's time for lovemaking, you say, pardon me, take your vial, take your syringe, load it up, give yourself a little injection on the bottom side of the penis on either side, 3 o'clock or 6 o'clock position. You got to make a little sound effect, boop, little sound effect. 15 minutes later, you start your lovemaking, your foreplay, and you're going to get that good erection. But there are side effects. The big one is something called priapism. Priapism is a prolonged erection. In other words, the erection will not go down. That happens when there's either too much drug, too much stimulation, or other things that we don't need to go into today. But what happens is blood sits in these cylinders. It's just going to sit here in these what's called the corpora, and these cells are going to use up all that oxygen, and then the cells start needing that oxygen. It's like a heart attack of the penis. It's called priapism. Other side effects, it hurts. It's a needle. There's bruising. There's a little swelling. Scar tissue can happen. And also some guys just don't like using needles. There's vacuum devices. We use a lot of vacuum devices in my clinic just because we use it to expand the tissue. We use it to help get the blood supply. But I will say, anecdotally, I have not seen a lot of guys happy using it when it just comes to intercourse. You have to use what's called a constriction ring. Those are rings that go on the base of the penis to hold the blood in after the vacuum pulls the blood in. But a lot of times I will use this before patients need implant surgery because there's some evidence that it improves the blood supply. It expands the tissue to help with implant surgery, which we're going to talk about in a little bit. I'm not even going to talk about Muse, M-U-S-E. This is the urethral suppository. I guess I am going to talk about it. Very expensive, doesn't work well. Let's move on. So let's talk about the ultimate. Let's talk about the Mercedes-Benz, the Bentley, which is the penile implant. So the penile implant's been out for decades. It's been the tried and true. It has been one of the cornerstone treatments for men with severe erectile dysfunction. Once it's put in, it's a guaranteed erection. The statistics are fantastic. The success rate is extremely high. The satisfaction rate is ridiculously high. Almost all guys say, I wish I did this a year ago. There's a statistic out there that 88% of these implants are working at 10 years. In other words, they're still pumping up. If you saw someone with an implant and they were walking around naked in downtown Atlanta, first of all, they might get arrested, but you wouldn't even know that they had this in them. It's all concealed. It's there to maintain length of the penis. It's there to maintain girth of the penis. And it's supposed to maintain the feeling of having a natural erection. It is the gold standard for men with severe erectile dysfunction. So we got a little video. We're going to play it for you here, and I'm going to be quiet. Maybe I'll do a little bit of talking. So there's three parts of the penile implant. We also call it a three-piece. And what this does is you can see there's a reservoir, there's cylinders, and there's a pump. Once it's implanted and once everybody's healed up nicely, the man is instructed how to find the pump. The pump is squeezed a bunch of times. The fluid that's in that reservoir gets pushed into the cylinders and up he goes. You have a good time, do your business. And then when you're done, there's a little release valve. Squeeze that, squeeze the penis. The fluid that's inside, the sterile fluid, gets pushed back into the reservoir and you're done. You want to have sex 10 minutes later, pump it back up. You want to pump it back up and just hang your hat on it, have a good time. So it guarantees an erection every single time. So here we go. Satisfaction rate, 98%. Partner satisfaction rate, 96%. I mean, it just doesn't get any better than that. There's also a malleable device. So it is not being pumped. This is something that's always rigid. This is for someone where I want to kind of get in and out of the operating room a little bit faster. I would say there's a little bit of a less risk of infection. We'll talk about that in a second. And it's not as nice. It's always up. You're always rigid, but it's much easier to use. So if I have a patient that has dexterity issues, they're tough with their hands. Let's say they have Parkinson's or they've had really bad arthritis. This could be an excellent option for them. It's much easier. There's no working parts to it. It's up and it's down. So what are some of the risks? So this is very important, and I try to label this out for all men. The biggest risk, in my opinion, is making the decision. This is a tough decision. This is a surgery of no pain, no gain. If you don't want to have the pain, you're not going to have sex again in a good way. If you want to make the risk and you want to understand that you're going to be uncomfortable for about 2 to 3 weeks, it's a commitment. You have to think about orthopedic surgery. Think about the person who has back pain or hip pain, or they need a knee replacement. You can bum around with braces and Celebrex and meloxicam and all kinds of stuff for the rest of your life, or you can bite the bullet. You get orthopedic surgery. You'll have a recovery. You'll have to do physical therapy, but you're going to get better. And then your quality of life goes up dramatically. The next biggest risk is infection. The infection rate in non-diabetic patients, diabetes is very important here, is about 1%. Infection rate for diabetic patients is a little bit higher, 2 to 3%. Other side effects are some guys may not like it. They may say, it's a little bit shorter. Yeah, it might be a little bit shorter. I can only put in the size that you give me. You give me this big, I'm giving you this big. You give me that big, I'm giving you that big. Let's fit it to the camera there. Sometimes the devices move a little bit. Sometimes they hurt. Sometimes it breaks. I had to replace a guy's the other day. I put an implant in him about a year and a half ago. Everything was going nicely. And then all of a sudden it just stopped working. I had to go fix it. He should be great. I just fixed it the other day. I expect him to have a full recovery in about a week or two. And I think he's going to be very happy. And then it's a foreign device. It may try to erode through. The skin at the end may get thin from using it. And we call that an erosion. That's less common. So the good news is that it's covered by most insurances, specifically Medicare. And the majority of men who are getting this are under some kind of Medicare plan. There are some other plans that are out there that cover it if the coding is done. So if the coding is proper, in other words, if you have prolonged diabetes and your sexual function is not good, and we use what's called N52.1, which is erectile dysfunction due to medical disease elsewhere, which is diabetes, that might get covered. Or let's say you have erectile dysfunction from having prostate removal, that it might get covered. We're very good at working with your insurance company. We give you the information so that you can call your insurance company, but we're here to help you. We're not here to help the insurance company. So what are some questions? What's it cost? Out of pocket, it's expensive. And there are guys that are unfortunately under bad insurance plans, but they'll do whatever it takes to have an implant, and it will be expensive. I think the going rate is over $15,000. I do have financial people in our office that can answer those questions. Satisfaction. I mean, my joke, if you can't tell, I joke around a lot. My joke is don't say my name when you're making love. That's how satisfied things should be. Orgasms are not affected. The sensation should not be affected. I'm not going to be disrupting any of the nerves down in the pelvis. There are some guys out there that do have trouble orgasming as they get older, and I do have remedies for that. That's a whole separate subject. How long can the implant stay inflated? You can keep it inflated all you want for all I care. Don't recommend it. You should keep it up for at least a half hour so that you can have intercourse and put it back down. But if you want to have fun, put it up, put it down, put it up, put it down. Have a good time. When guys first get the implant in, I tell them to pump. And once I release them, I tell them to start pumping it up every day. And usually about 4 to 6 weeks after I put an implant in, that's when the patient would come back so that I can teach them how to inflate it and deflate it. There's usually there's usually a little bit of a time of healing before we can turn it on. Procedure takes me about an hour. We're on this question over here. Takes me about an hour. I don't work fast. I don't work slow. I like to make sure it's just right, but it is a process of getting it done. You will be in my surgery center or in the hospital for a few hours because you got to get checked in. We got to give you some antibiotics. We got to do a whole prep for you to sterilize the skin. I put a whole bunch of numbing medicine inside. So it is a process. How long does it take to inflate? Well, the bigger it is, the more it is to inflate. The smaller it is, the less it is to inflate. Some people can inflate literally in 5 seconds. Some people need 15 seconds. So it's interesting. Will anyone notice? Only if you show them. I have a guy in the practice who is in his 70s. I put his implant in about 3 years ago. He is enjoying life right now. He does not tell the people he's having sex with that he has an implant in, and they think that he's a superstar. Recovery, that's a tough one. You're going to hurt. Not going to lie to you. There's some people that don't hurt. I just operated on a guy. He says he had very little pain. I don't understand how. I think I would be in pain. Most guys are uncomfortable. I give everybody an antibiotic afterwards. I give everybody some kind of pain medicine. So there's a medicine called Siglentis. There's a medicine called Tramadol. There's good old-fashioned oxycodone. And your best friend is also an ice pack. And usually people are uncomfortable for a good 7 to 10 days. After 7 to 10 days, they're on just Tylenol or Motrin or something like that. And then they just keep getting better and better and better. No one lives with long-term pain. That is not our goal. I answered this already. When can I use the implant? Usually 4 to 6 weeks. Will it affect the size of the penis? I think I mentioned that before. Yeah. If you bring me a small penis, you're going to get a small implant. If you bring me a big penis, you're going to get a good implant. You have to go by size. If I put something in too big, it's going to erode. If I put something in too small, it's not going to fit. So I measure you. When you're asleep, we measure what the insides of the penis is called the corpora, and we tailor it to the individual. A lot of guys, I will do a vacuum device beforehand, and the idea is to just pull that penis open, pull it so that it fills, so that maybe you'll get an extra centimeter at the time of surgery. Away from work, it depends. A lot of people work from home these days. So you may want to just take a week off from answering emails and answering phones and logging in. But if you're just taking Motrin and you're sitting with an ice pack, honestly, you can work. If you're doing heavy lifting, you're benched. You're on the bench for 3 weeks. Do you have to stay in the hospital? We try not to do this in the hospital. We try to do this in our surgery center. But if we did it in the hospital, it's outpatient. And even if we did it and when we do it in the surgery center, it's an outpatient. People go home with no Foley catheter. There's no catheter in the penis. and they go home usually about an hour or two after the surgery. Workouts, I usually tell people they're benched for a few weeks. I don't want lifting and straining. I don't want them to ruin the work. I don't want them to say, oh, I feel great, and then they go and do a little bit of jogging, and then all of a sudden a suture pops. That's the last thing we need. So I usually bench people for about 3 weeks. Let's see. So you're more than welcome to go online and see who does these implants. There's a lot of people in Atlanta. There's a lot of people all over the country. There's not every urologist does this. Some urologists do a lot. Some urologists do a little. Some urologists do a significant amount. So we kind of ran through this because it's kind of a good staple talk. It covers a lot. There's a lot of information on the internet. There's videos. I have a previous video that we did for this a couple of years ago, and this was just an updated one. It's been a while since I've done this talk, so I just wanted to do it again just to update things. I can't say that anything has changed dramatically in the last couple of years. I think every year protocols change a little bit. In other words, the antibiotics we use may change a little bit. The Coloplast may update their device a little bit. They may make a little tweak to the mechanics of it every once in a while. But we've been so happy with their device called the Titan that we're just going to keep using it. I think it's a wonderful device. I think they provide excellent care to our patients and excellent service. And when I got a question, they answer the phone, because not everything's simple. Not everything's straightforward. Everybody's got a little tweak to their system. And when I have something of concern, I call the reps, and they're very, very helpful and very, very good with feedback. So once again, Marc Greenstein. I'm one of the urologists at Advanced Urology in Atlanta. And I think our number is somewhere on one of these slides. I think it was on this slide. Let's put this back. You got to thank all the people who publish stuff. And there it is. So that's our office. That's our website. You are more than welcome to look us up if you have any interest in coming to talk to any of the providers that do this. I'm one of them. We have a whole bunch in our practice that does these.